So next we're going to talk about some specific adrenergic agonists. So the most common one that you guys use pretty much every day is phenylephrine. And it's a pure alpha agonist. It increases both venous constriction and arterial constriction in a dose-dependent manner. And usually at normal dosing, you have more venoconstriction than arterioconstriction. So it increases the venous return, so it increases stroke volume, and at the same time, it can induce a reflex bradycardia secondary to a vagal reflex. So cardiac output may not be increased. Phenylephrine doesn't change cardiac output in normal in people that are not under anesthesia, have normal blood pressure, and it can actually decrease their cardiac output in patients with ischemic heart disease. But it's very useful in reversing right to left shunts in tetralogy of Fallot when patients are having spells during anesthesia. So essentially, the only time most people use phenylephrine in a pediatric patient is to treat a spell. Now, why is it so useful under anesthesia? Under anesthesia, you have vasodilation, arterial dilation, and venodilation that happens from inhalation anesthetics or propofol. And phenylephrine directly counteracts that. So under anesthesia, when you're treating hypotension, it does increase cardiac output. And you got to understand that this is very different from somebody who's not under anesthesia. Norepinephrine produces direct-acting hemodynamic effects on the both alpha and beta receptor, again, in a dose-dependent manner. It increases your cardiac output and blood pressure when given in low doses, and higher doses reduce flow because of arterial constriction becomes more prevalent. Reflex baroreceptor-mediated bradycardia definitely can occur despite actively stimulating the cardiac muscles too from the beta-1 receptors. Complications like tissue necrosis may be expected when norepinephrine use, and you probably have seen it in your ICU rotations, patients in shock, high-dose norepinephrine, and other pressors, and they end up with tissue necrosis. So, should we use norepinephrine in cardiogenic shock? Sorry about the misspelling. So, there are some objections to use of norepinephrine for treatment of shock, especially cardiogenic shock, based on two specific considerations. First one, vasoconstriction increases the pressure work of the left ventricle, and this worsens the oxygen economy of the ischemic pump. That's obvious. And the second one's that norepinephrine causes vasoconstriction and organ ischemia in a syndrome in which there is intense constriction already in place. So there are some additional undesirable effects associated with norepinephrine, like renal arterial constriction that results in oliguria. So what are some indications for norepinephrine? So reduced vascular tone states with or without cardiogenic shock is the main indication for norepinephrine. It can be used for its inotropic effect at low doses and titrated to effect while monitoring the cardiac output. But again, monitoring the cardiac output is the big picture. Monitoring the blood pressure alone or titrating to a predetermined effect is usually detrimental, and that can decrease your cardiac output. So, blood pressure increases are usually due to increased systemic vascular resistance, which can actually decrease your forward flow and make your cardiac failure worse. Even moderate doses of norepinephrine may worsen end organ perfusion. So, that doesn't sound right. So when do we use it? In those clinical situations where there is high output to low tone states with a low perfusion pressure. And in these clinical conditions, norepinephrine has been shown to improve renal and splanchnic blood flow by increasing pressure, provided that the patient has been volume resuscitated. So if you need to give volume, you got to give volume first. If the patient is hypovolemic, norepinephrine is not going to help. It's actually going to make things worse. So norepinephrine is the first line of treatment of hypotension in septic patients. What about epinephrine? Synthesized, stored, and released from the adrenal medulla. dose-dependent direct stimulation of both alpha and beta receptors. Its effects on the peripheral vasculature is mixed, and it has predominantly alpha effects in some vascular beds like skin, mucosa, kidney, and beta stimulating action in other tissue like skeletal muscle. At therapeutic doses, beta-adrenergic effects predominate. In the peripheral vessel and systemic vascular resistance may be actually reduced. Constriction, though, is maintained in the renal and cutaneous area because of its alpha-dominant effects there. An increase in cardiac output with epi can be due to a redistribution of blood to low resistance vessel in the muscle, but if you increase, but it can further reduce the flow to the vital organs. Cardiac arrhythmias can occur with no epinephrine, and it's one of the major concerns when you use a beta-1 stimulating agent, and epi has other receptors it activates, but the beta-1 receptors activators are usually arrhythmogenic. Ephedrine. It's predominantly indirect acting pressure. It causes release of norepinephrine. Can have tachyphylaxis pretty quickly because norepinephrine stores are limited, and especially in patients in shock, there may be no additional norepinephrine in store, so it won't work. And effects are nearly identical to those of epi, but it's not as potent. Its effects are sustained about 10 times longer than those of epi, so it's still a short-acting drug, but it's much longer than epinephrine. It produces venoconstriction to a greater degree than arterioconstriction. This has become a theme. And it causes distribution of blood centrally, improves venous return and cardiac output, and restores uterine perfusion. The mild action restores heart rate simultaneously with improved venous return. But an increased blood pressure is noted as a result rather than a cause of these events. Mild alpha-1 arteriolar constriction does occur, but the net effect of improving venous return and heart rate is increasing cardiac output. So at least theoretically, it's a more physiologic vasopressor. Uterine blood flow is spared, and isoproterenol is a potent, balanced beta-1 and beta-2 receptor agonist with no vasoconstrictor effect. It doesn't affect the alpha receptors. It increases heart rate and contractility while decreasing systemic vascular resistance from the beta-2 receptors. It can increase cardiac output, but it's not useful in shock because it redistributes blood to the cutaneous and muscular vessels, so you lose your preload and your afterload as well. Produces unpredictable results on cardiac output and blood pressure because of the beta effects. Isoproterenol is a potent dysrhythmogenic drug and extends myocardial ischemic areas. So if somebody's having a heart attack, you give isoproterenol, the heart attack will get worse. And deleterious effects on the evolving cardiac ischemia process include arrhythmia, tachycardia, reduced diastolic coronary perfusion pressure, and time. And is helpful in managing cardiac failure associated with bradycardia, asthma, and cor pulmonale. It's also useful as a temporary chemical pacemaker in third-degree heart block. So if you're in the middle of nowhere, you don't have access to electricity, and you have a pump that operates on battery, you can use this. One of the most important drugs used for denervated heart in cases of significant bradycardia. So somebody has had a heart transplant. This works beautifully in terms of increasing their heart rate. Atropine does not. Isoproterenol might be useful in treating both idiopathic and secondary pulmonary hypertension. It's not a standard drug for it, though. It's also been reported as a useful treatment modality in improving the forward flow in patients with regurgitant aortic valve disease. But it should not be used if there is an accompanying stenosis. If you give it to patients with aortic stenosis, you lose your afterload. Patients will die. eventually. Dobutamine, things that you almost never will use, but there are still some test questions about it. It acts directly on beta 1 receptors, but exerts much weaker beta 2 stimulation than isoproterenol. So similar to isoproterenol, but more beta 1 specific. Doesn't cause norepinephrine release or stimulate dopamine receptors. Has a weak alpha 1 agonism. Increases heart rate more than epinephrine for a given increase in cardiac output. May decrease diastolic coronary filling pressures because of its vasodilation effect, but it appears to produce coronary vasodilation in contrast to the constriction produced by dopamine. So these differences are important points to remember for test questions. So you get vasoconstriction with dopamine, vasodilation with dobutamine. That's pretty much why you never use dobutamine alone. It's always with a vasoconstrictor like norepinephrine. After MI, dobutamine can improve coronary flow to the dyskinetic areas. It's not a vasoconstrictor, unlike dopamine again. It is less likely to increase heart rate than dopamine for a given dose. So dopamine is a more chronogenic, if that's a word, compared to dobutamine. It's a coronary dilator, unlike dopamine. Both dopamine and dobutamine have contrasting effects on pulmonary vasculature, and this is more of a hotbed for questions. Dopamine has been noted to increase pulmonary artery pressure and doesn't inhibit the pulmonary hypoxic response. It's not recommended for patients in right heart failure. But dobutamine does vasodilate these pulmonary vascular beds and is helpful in treating right heart failure and cor pulmonale. The net effect of dobutamine: increased cardiac output, decreased LV filling pressure, decreased SVR, no significant increase in heart rate at clinical normal low dosing. So if you can remember one slide for dobutamine, this should be it. Dopamine is used in treating the low output syndrome. It's a dose-related agonist to all three types of adrenoreceptors, and the desired action can be selected by changing your infusion rate, at least theoretically. Dopamine receptors are most sensitive to beta first and alpha second. Not the dopamine receptors, but the receptors that dopamine activates. So low-dose dopamine, what does that mean? Less than 2 mic per kilo per minute. You have dilation of the renal and mesenteric vasculature, tubular cell natriuresis. The hemodynamic effects are primarily from vasodilation, because you get activation of dopamine 1 and 2 receptors. Then you get activation of presynaptic dopamine 2 adrenoreceptors, and it adds to the vasodilating effects of the DA1 receptors because they're inhibiting presynaptic norepinephrine release in the renal and mesenteric vessels. A reduced diastolic blood pressure is often noted with a slight reflex tachycardia. And moderate dosing is 2 to 5 mic per kilo per minute. It begins to activate some beta receptors now. So we're moving to beta in addition to alpha. So we get increasing cardiac output from increasing the heart rate and contractility. Again, early venoconstriction from preload, decreasing systemic vascular resistance. Blood pressure may not increase despite significant increase in cardiac output. And this dose range kind of appears optimal for managing CHF and lung failure because it combines inotropism and afterload reduction with possible diuresis. Now, at doses of more than 5 to 10 mic per kilo per minute, you begin to activate alpha receptors. I think on the last slide I said alpha, I meant dopamine for the low doses. But when you get more than 5 mic per kilo, you begin to get alpha receptors. And then you have increased SVR and blood pressure. further increase in cardiac output may be attenuated at this point because of increased afterload. High-dose dopamine behaves very much like norepinephrine. It also causes norepinephrine release. And despite the apparent dose-response divisions of dopamine, a wide variability of individual responses has been noted. That's why I said at least theoretically, because clinically this doesn't fit the picture. Dopamine increases the mean PA pressure, so it's not recommended as a sole agent in patients with right heart failure, adult respiratory distress syndrome, or pulmonary hypertension. Now, this is a comparison of relative alpha-1 catecholamine response on peripheral resistance and capacitance vessel. So you can see here, phenylephrine, a little bit more venous than arterial. Epinephrine, similar degree of alpha-1 subtypes of venous and arterial. When we move to the actions of the adrenergic agonist, you can see phenylephrine primarily alpha-1, norepinephrine alpha-1, alpha-2, and beta-1. Epi and ephedrine very similarly stimulate everything except dopamine receptors. Dobutamine, kind of like the epi, except it doesn't have the alpha sites. And isoproterenol in the bottom, I didn't put a square around it, but you can see that's a pure beta, both beta-1 and beta-2 receptor. Now, some dose schedules and the hemodynamic effects of the adrenergic agonist. So you can see norepinephrine can actually result in a increased venous return and total peripheral resistance, which would lead to decreased renal blood flow, reflex, decrease in the heart rate, and potentially decrease in cardiac output from that decrease in heart rate. Epinephrine, the cardiac output effect and inotropism can be up or down. You get reflex and you get increase in heart rate, increased venous return, peripheral resistance, and significantly reduced renal blood flow. So when you have somebody on epinephrine and you see urine output is low, you give Lasix. Lasix results in increase in oxygen demand and ATP consumption in your loops of Henle, and that leads to even more ischemia. Ephedrine, you can see you have increase in total peripheral resistance, increase in venous return, increase in heart rate, all of which lead to increase in your cardiac output. So at least theoretically, it's a physiologic agent to increase your cardiac output. Dopamine, you can see the dose response. Dobutamine, you can see the venous return and total peripheral resistance going up. Renal blood flow can be up or down. And isoproterenol, you can see the result from primarily activation of beta-1 and 2 receptors. Now, a drug you probably will never use, phenyldopa. It's a selective DA1 agonist, dopamine 1 agonist. Doesn't have any alpha or beta receptor activity. It's a potent direct renal vasodilator, and it results in direct natriuresis and diuretic properties and a potential, and promotes an increase in creatinine clearance. Can be used in renal failure patients for acute resolution of severe hypertension, and that's become useful because sodium nitrite, the nitrite or sodium nitroprusside, is contraindicated in patients with severe renal failure. The most common adverse effects of this drug are related to vasodilation, can be hypotension, flushing, dizziness, headache, tachycardia, nausea, or hypokalemia. And in glaucoma, it can increase intraocular pressure. I think I've seen this glaucoma and intraocular pressure with phenyldopa in a couple of different scenarios being asked in test questions. My favorite drug, clonidine. It's a central-acting alpha-2 agonist, and 220 to 1, depending on the source you use, for specificity for alpha-2 receptors. It decreases central sympathetic outflow. And when you stimulate the alpha-2 receptor in the vasomotor center of the medulla, then you get the effects of clonidine. Peripherally, there is decreased plasma renin activity, and you also have decrease in epi and norepinephrine levels. There is dose-dependent analgesia when introduced into the epidural or subarachnoid space. So you can see, actually, I think Emmett has been using clonidine in his pediatric spinals. It can produce hypotension, bradycardia, and sedation. And other benefits of using clonidine as your pre-medication are blunting the reflex tachycardia from the intubation, reduces vasomotor labiality, decreased plasma catecholamines, and dramatic decrease in MAC for inhaled gases or injected anesthetics. The elimination half-life of the drug is 9 to 12 hours, so you gotta keep that in mind. And the most common side effects are sedation and dry mouth. Impotence and orthostatic hypotension can definitely happen with clonidine from the alpha-1 effect. My second favorite drug, dexmedetomidine, is a more selective alpha-2 agonist, and again 1600 to 1 alpha-2 specificity and much shorter half-life of 1.5 hours. Onset of action about less than 5 minutes, and time to peak effect is about 15 minutes. Provides sedation, reduces blood pressure, heart rate, and profoundly decreases plasma catecholamines. There is no respiratory depression with massive overdose of dexmedetomidine. And there are some papers, especially it came out a couple of years ago, that are saying that dexmedetomidine could result in decreased oxygen saturation. But what they failed to control for was the patient with sleep apnea. If you obstruct, desaturate when you fall asleep. You obstruct and desaturate when you get dexmedetomidine. It's not a respiratory depressant. Pretreatment with dex, kind of like clonidine, gets rid of your hemodynamic response to intubation. And it decreases the MAC for volatile agents from 35 to 50%, but increases the likelihood of hypotension. Again, like clonidine, it increases the range of temperatures, not triggering thermoregulatory defenses. So if it's the only option for you to choose when somebody asks about how to treat shivering, you can use dexmedetomidine or clonidine. They're not the first agent, but they can be used. And it's likely to promote peri-op hypothermia, but is also effective against shivering.